Today we have very important topics to discuss, some of which are not part of daily practice for most of us, but we're expected to know them to detail. So this presentation is very important to be able to understand the nitty-gritty involved in these procedures that we'll be talking about today. So to start the ball rolling, we have Dr. Ozo, who will be taking us on left heart catheterization. And after which we would have Dr. Okori to take us on cardiac transplantation. Okay. So Dr. Ozo, if you're ready, the floor is yours.
Okay, good evening, my chiefs and senior colleagues. I want to thank everyone for this opportunity to lead today's presentation. And today we'll be discussing on left heart catheterization. Please, I don't know if everyone can see my slide and if I'm audible enough.
Yes, we can hear you loud and clear. And
okay, all right, thank you very much. So we'll be taking up today's discussion in this outline. And then by it seems someone is saying something, or should I continue, please?
Please continue. I'm trying to mute them in the background. Continue.
Okay, all right, thank you very much. So by way of a general overview, cardiac catheterization is a procedure which involves inserting a catheter to access diseases, abnormalities involving the coronary arteries, the heart, the valves, and then the pulmonary vasculature. We all know that an echo is a surrogate for measuring pulmonary pressures. However, cardiac catheterization is actually the gold standard for measuring all these values. Now, routine catheter access is obtained from either the radial or femoral artery and a convenient vein in most situations, and then advance into the heart, either via the right atrium or the aorta, as the case may be, either right heart catheterization or left heart catheterization. And pressures can be measured directly, as well as direct visualization of other structures to be examined and imaging modalities taken as well. Then the radial artery approach has gained wide acceptance and demonstrated reduced bleeding complications related to femoral access. In certain procedures, you want to choose the access, or you want to adopt a method that comes with lesser complications, especially if there are several other or maybe like two modalities to use. Now, many laboratories now use the radial access as the default approach for routine cardiac catheterization. And there are many patients that undergo cardiac catheterization before non-cardiac surgeries, even though it is not routinely indicated. In a report from the National Cardiovascular Data Registry, called the CAT-PCR registry, most of the patients undergoing diagnostic cardiac catheterization before non-cardiac surgeries were found to be asymptomatic. And discovery of obstructive coronary artery disease was common, and revascularization was recommended in nearly half of these patients. Now, by way of definition, as a focus on our main topic today, left heart catheterization is a minimally invasive medical procedure used to diagnose and treat heart conditions, as it provides detailed images of the coronary arteries, the left artery, the left chambers, as well as the valve itself. And during this procedure, a thin, flexible tube called a catheter is inserted through an artery in the groin or wrist, depending on the radiofemoral access, and guided to the left side of the heart. In the left heart catheterization, the tube is usually inserted into the left side via the left radial approach of into the heart chambers via the aortic valve, usually under fluoroscopic guidance for diagnostic or therapeutic purpose. And contrast media I use may here, may be injected to visualize the coronary arteries, left ventricle, and other structures using X-ray imaging. You can just do a direct cardiac catheterization without injection of contrast dies. So the main importance of left heart catheterization actually serves one for coronary angiography, which is essentially to diagnose coronary artery disease, to evaluate coronary arteries stenosis or blockages, and then ventriculography, which assesses the left heart function, ventricular function, assessing the pumping activity of the heart. We also help to diagnose valvular heart diseases, tumors of the heart, and then heart defects, especially congenital or acquired, such as ventricular septal defects, collect samples, and then also to collect biopsy samples from tumors of the heart, or in specialized situations, such as if we want to diagnose maybe some form of infiltrative cardiac diseases and all that. Then I also said following cardiac catheterization, a dye may be injected, in which case a dye may be injected when we also want to look at or study the coronary arteries, in which case you also want to do a coronary angiography. And usually coronary angiography and the left heart catheterization usually actually go together. So in angiography, a radiopaque contrast media or dye, which is a liquid that can be seen on X-rays, is injected into the coronary vessels, and X-rays are taken to produce detailed images of the blood vessel. And then coronary angiography provides information about the coronary arteries, which supply the heart with oxygen-rich blood, and is usually done during left cardiac catheterization, because the coronary arteries branch off the aorta just as it leaves the left side of the heart, and the two procedures usually go hand in hand. So this is actually a diagram showing an angiographic procedure with the access here using the femoral artery. So in cardiac catheterization, in which you want to also do a study of the coronary arteries, you may want to do some kind of angioplasty with or without stenting. So left heart catheterization is a valuable diagnostic tool for patients with suspected heart disease, usually providing detailed information to inform treatment decisions and also to improve patient outcomes. We also want to give the best to our patients. So I'm here. I've said that we can do that without any coronary angiograph. However, the coronary angiograph involves injecting a dye to visualize the coronary vessels to assess both dynamic and adynamic obstructions, such as coronary artery vasospasms or other abnormalities involving the coronary circulation. And use of in-lab portable echocardiographic facilities facilitates access for both radial and femoral arteries with reduced complications. And in most cases, an antecubital vein on the same arm is often used especially for right heart catheterization, when using the radial approach for arteriography and left ventricular hemodynamics as well. And if there are blockages, just like I've said, we may perform an angiography, which with or without stenting, which is a way of opening up the blood vessels, as the case may be. And in addition to standard arterial and venous vascular access, there are a variety of special access techniques that may be required for optimal hemodynamic assessment. Now, apart from the conventional radial or femoral access to left heart catheterization, there are also usually other methods, specialized measures that may be adopted depending on what is being investigated or evaluated. You have the transeptal access to the left atrium or ventricle, which is most often employed when prosthetic valves are located either in the aortic or mitral positions. You also have the direct left atrial measurement via the transeptal approach. It is also highly desirable, if not critical, to accurate decision-making in conditions such as mitral stenosis, in which the pulmonary capillary wedge pressure is unreliable as a surrogate for the left atrial pressure. Then, under fluoroscopic guidance, the transeptal access is also obtained using a broken barrel catheter that is passed through the atrial septum over a long needle that is used to puncture the septum at the fossa ovalis. Now, this technique is commonly used for accurate assessment of mitral valve diseases and as an access or mitral balloon valvuloplasty and a clip technique for percutaneous repair or secondary mitral regurgitation. Now, also access to the pericardium using long needles or specialized curved tip needles permits introduction of catheters into the pericardial space when pericardial effusion requires evacuation, especially when you have large pericardial effusion to be cleared. Now, pericardial catheters can measure pericardial pressure for the assessment of clinical tamponade or congestive heart failure symptoms or hypotension of unexplained etiology in a setting of echocardiographic evidence of pericardial fluid. Now, pericardial access has been used for the treatment of arrhythmias and left atrial appendage occlusion as well. Now, here are other specialized techniques involved in either left or heart catheterization. I've said we have the transeptal puncture technique. We also have the direct left ventricular puncture. We have the dual high fidelity micromanometer catheters, multiple arterial access, long sheet double lumen catheter use, and then also have specialized techniques for endometrial biopsy. We also have the transcoronary pressure stroke flow velocity. And then here is a picture of a catheter with the various labels and position. You have the proximal lumen. You also have the terminal connector and all that. This is a picture of a catheter with its various components and different function. So it's also important for us to discuss the various types of catheters. In left heart catheterization, several types of catheters are used for various purposes. Now, the following are some of the commonly used types that we have. You have the Judkins catheter, which is used for coronary angiography, and it has a P-shaped curve to facilitate engagement with the coronary ostia. We have the Amplatz catheter used for left ventriculography and coronary angiography. It has a more pronounced curve than the Judkins. We also have the multi-purpose catheter, which is vascular catheter for coronary angiography, left ventriculography, and also aortography as well. We have the Tiger catheter used for coronary angiography. It has a unique shape to access difficult to reach coronary arteries. This is why this was actually created, to show difficulties. Now you also have the extra catheter, which provides additional support and stability during procedures. You have the intravascular ultrasound catheter used for imaging the coronary arteries and accessing plaque morphologies as well. You have the pressure sensing catheter, which measures pressure gradients across coronary lesions or valves. You also have the oximetry catheter, which measures oxygen saturation in the left heart catheters. Somehow, this also helps us to understand the various types of maybe atrial septal defect and reticular septal defect by way of their oxygen concentration. You also have the temporary pacing catheter, which is used for temporary pacing procedures. Now, it's also important to understand that each catheter type serves a specific purpose, and the choice depends on the individual patient needs and the procedure requirements as well. So I've also tried to make pictures of the different types of catheter. However, the other one on the left is actually quite small. Then this is also a picture showing the different types of catheter and their diameter sizes, and then the flow quantity that is measured. I wouldn't want to take much of time on that because I'm going to drop the slide later. Now, very importantly, there are distinct indications for left heart catheterization. However, I think because I wouldn't want to jump out with the talk of slides, I've decided to compare the indications as follows. We have said that essentially left heart catheterization is a measure to investigate the coronary arteries and then to look at the left heart chambers, most importantly. And then the indications which has been summarized include as listed here. First, you have evaluation and treatment of suspected cardiac abnormalities or coronary artery disease in patients with chest pain of uncertain origin, especially when non-invasive tests are not diagnostic. Or sometimes we have there are some instances we have diagnostic dilemmas, especially in situations where we have patients presenting with chest pain. There are sometimes you have a patient presenting with chest pain that you're suspecting that has, we had a case, a patient presented with chest pain, typical angina-like chest pain. The cardiac troponins was normal. We did a CTPA, it was normal. And then I think D-dimer 2, I think was normal. I can't really remember that. Of course, in this condition now, the next thing that this patient would have benefited from is a cardiac catheterization. However, I think it's only Lagos they do that also, I'm not sure. Then you also have assessment of the severity of valvular or myocardial disorders such as aortic stenosis, aortic insufficiency, mitral stenosis, mitral insufficiency, and then cardiomyopathies. And then to determine the need for surgical correction when there is a discrepancy between signs, symptoms, and echocardiographic findings. And then we also, in most situations, we also want to assess an evaluation of a coronary artery bypass, especially if we suspect post-surgical or post-intervention malfunction. We also have evaluation and treatment of cardiac arrhythmias, and then percutaneous closure of congenital cardiac defects such as atrial septal defect and ventricular septal defect, as well as a PDA. And then treatment of valvular heart disease such as valvuloplasty or percutaneous transcatheter valve replacement. We also have collection of data to confirm and complement non-invasive studies. Of course, in most situations, when we have diagnostic dilemmas, following use of the non-invasive studies, this is where cardiac catheterization, and in most cases, left heart catheterization comes in. Of course, for every procedure too, we also have contraindications. Now, it is important to understand that there are no absolute contraindications to left heart catheterization other than the patient's refusal for the procedure. However, the relative contraindications may include the following, however, usually not limited. We have severe uncontrolled hypertension, we have unstable arrhythmias, we have acute cerebrovascular accident or stroke when there are situations of active bleeding, and then allergy to contrast media, renal dysfunction if there's renal impairment, either acute or chronic, when there's acute pulmonary edema or heart failure, especially when the patient is unable to lie flat, and then untreated active infection. In most cases of cardiac catheterization, most deaths are due to untreated acute illnesses. So in most cases, you want to treat most underlying situations before venturing into that. That's why part of the pre-op preparation is a complete evaluation of every patient. Then you also have when there are severe coagulopathy, and then when there's encephalopathy, significant peripheral artery disease. And then in most cases too, if a patient has a platelet count less than 35,000, you would not want to take up the patient for a cardiac catheterization procedure. Then we have some equipment, although the cardiac catheterization is done in the cath lab. However, it's important for us to know that this equipment, the cardiac catheterization laboratory, most importantly, is very important. And you have a fluoroscopy machine, hemodynamic monitor, different diagnostic and guide catheter, like we have said, guide wires, manifold for contrast injections, coronary wires, balloons, stents for percussion, coronary interventions, and the rest of them. Then, besides the equipment, so there are also some important personnel for left heart, for cardiac catheterization generally, as well as left heart catheterization. Meanwhile, it's important to know that the procedure is a multidisciplinary procedure requiring a cardiologist, especially an interventional cardiologist, having experts in diagnosis and interventional cardiac catheterization, cardiovascular technology to assist the cardiologist, cardiac catheterization, also administration of drugs, radiographer, anesthesiologist to assist in sedation. So as part of the procedure, we usually oral anticoagulation or even IVs are stopped at least 24 hours before the procedure, depending on the creatinine clearance as well. We all have guidelines guiding the time of stoppage for anticoagulants as part of pre-op procedure preparation. However, before the procedure, a thorough history should be taken with special emphasis on contrast allergy. We all know that prevention is better than cure. So a detailed examination is done to assess the access site, and then peripheral pulses are usually documented. Now, laboratory investigations are important, including hemoglobin, platelet count. I've said you would platelet count less than 35,000, usually not permissible for cardiac catheterization. And then the creatinine clearance, very important for everybody. And then history of contrast reaction. And then in diabetics too, we also have to be careful about that. Especially in diabetics, the EGFR, the aberrant creatinine ratio is important, such that we will be very, very careful with contrast nephropathy. And to avoid this, it is totally advised to explore other alternatives. Then the operating provider should obtain informed consent. The procedure should be explained in details, very important, including risks and complications associated with the procedure. I'm so sorry, I don't know if this is clear. However, these are usually part of the components of the informed consent form, which is to be signed before a cardiac catheterization procedure. Because besides oral explanations, it's important that you have all these things documented, especially for medical legal reasons. So these are the components, not exhaustive, parts of the consent form before a cardiac catheterization procedure. Sorry, this last one here is actually a full consent form. However, it is not cleared. And then usually to an intravenous normal saline should be administered to prevent contrast-induced renal dysfunction in some cases, especially in those with underlying renal dysfunction. And then after shifting to the catheterization lab, the patient is placed in a supine position on the table. Access sites are sterilized and the patient is drilled. And then all cannulas, needle, and catheter are flushed with heparinase saline as usual. And cardiologists and assistant technology do the usual thing. And then, however, the summary of the procedure is that the catheter is inserted through an artery in the groin or wrist after complete sterilization. And then the catheters are guided to the left side of the heart. And then contrast media is injected to visualize coronary arteries and the left chambers. And then X-ray images or angiograms are taken to show the coronary artery anatomy and potential blockages requiring intervention, and then evaluate left ventricular function and wall motion, and then measure hemodynamic variables. Then for the techniques for the arterial access, the arterial access from the upper hand, the radial access, there's one that is called the modified Sons method, usually preferred. And for the radial access, it's better to perform a Bravo or Allen test to assess collateral circulation adequacy to the hand. So you would not want to, you wouldn't want to start up with a radial access without doing this, so that you have to be sure of the collateral circulation. And also, before the radial access, the patient is usually pre-medicated with either midazolam, fentanyl, or nalbuphine. This is actually to avoid radial spasms that may be provoked by just anxiety. And then in general, the steps involved in cardiac catheterization: one, you have preparation of the patient. Patient is prepared with IV access, ECG monitoring, and blood pressure monitoring. And then the access, a small incision is made in the femoral artery or groin area, or radial access to gain the access. And then shoot insertion into the artery to facilitate catheter insertion. And then the catheter advancement, the guiding wire is advanced through the sheath to the left side of the heart. And then engagement, the guiding catheter engages the coronary ostium opening, and then you now have contrast injection, angiography, taking images, and then pressure measurements. And then after that, the catheter and sheath are removed, and then hemostasis is secure. It's also important to note that the steps are general overview and may vary depending on individual patient needs and circumstances. And then if we're going to do a radial access, it is usually advised to to have a radial puncture at about 2 to 3 centimeters above the wrist crease, where the artery is best palpable. And then if you want to do subsequent attempt, it should be at least 1 centimeter proximal to the initial puncture site. Then there are usually absolute contraindications to the radial artery access for left heart catheterization. One is if in a patient who lack adequate collateral circulation, of course, the Allen test will tell you that. Then patient with abnormal result from Allen test or plethysmography, and patients who may require an intra-aortic balloon pump, and then patients who may require devices that are not compatible with sheaths smaller than 7 French, and then patient with no non-upper extremity vascular disease, vasculitis or thereabouts, and then especially catheterization disease, and then patient with Brugger's disease, and then any patient that has Raynaud's disease as well. Then the relative contraindication to the radial artery access for left heart catheterization, we have patients with chronic kidney disease who may need an arteriovenous fistula in the future. We have to consider this. And then patients with renal phenomenon, like we said, and then women with short stature and weak radial pulses, then patient with non-severe innominate subclavian artery disease, and then patient with non-internal mammary grafts collateral to the site of the entry. Then following this, we can now venture into measuring the hemodynamic variable. So in the course of the cardiac catheterization, following the arterial access, we have said that the important thing about cardiac catheterization is assessing the left chambers of the heart. So one can do a coronary angiography, and one can also assess the aortic valve and the mitral valve as well, and then do a complete ventriculogram. And then we also have hemodynamic variables that are also assessed during left heart catheterization. One is direct measurement of the pressure, left ventricular pressure, aortic pressure, and the left atrial pressure as well. We all know that echo is a surrogate or indirect measurement of this. And then the cardiac outputs can also be directly measured because these have pressure sensors, just like I've stated in using the different kinds of catheter that we have said they serve different purposes. We also measure the vascular resistance, so that's systemic vascular resistance, the pulmonary vascular resistance, as well as the direct measurement of the pulmonary capillary wedge pressure. We also have the oxygen saturation. Each of these catheters, like I have said, serve for these different purposes. Then you can also measure the flow rate, which includes the coronary flow reserve and then the fractional flow reserve as well. And then the measurements obtained in this procedure are done using pressure transducer that are attached to the catheter. We also have thermodilution techniques, which involve injecting saline to measure the cardiac output, and then also the Fick's principle, in which there is calculation of cardiac output based on oxygen consumption, and then angiographic analysis as well, in which we assess the coronary flow and vascular resistance. And then the importance of these hemodynamic measurements help us to make detailed analysis or diagnosis of heart failure, valvular heart disease, coronary artery disease, and then cardiomyopathies as well. And then this accurate measurement of this will help us to assess disease severity, guide treatment decisions, monitor response to therapy, and then improve the patient's outcomes. Now, for the risk of complications of left heart catheterization, of course, every procedure, one of them is bleeding or hematoma at the access site. Of course, this is usually prevented post-procedure by securing hemostasis. Then we also have the contrast media allergic reaction, or the non-contrast or contrast-induced nephropathy. However, to minimize this problem related to contrast induced or contrast reactions, Of course, we have the ionic media and then the non-ionic media. The only thing is that the ionic media, which are less expensive, have a higher incidence of adverse reactions. The non-ionic media have lesser incidence, not as if it is totally zero. They have lesser incidence of ionic reaction. This has to do with their solubility and then their osmolarity. The ionic media are usually of higher higher osmolarity, while the non-ionic media have smaller osmolarity, and then they have lesser chance. It's not as if it is completely zero, but they have a lesser chance of allergic reactions. And then one of the ways to prevent this each problem related to contrast media allergic reaction, part of the non-ionic media. One of them is the adoption of carbon dioxide use in left-heart catheterization. The benefit is that it is an alternative to conventional iodinated contrast compounds, particularly in situations where there is contraindication to iodinated compounds. One of the benefits is that it reduces the chance of this contrast-induced reaction. However, if you want to do, if you want
Oh, hello. I think we've lost Dr. Ozo. Please, your
left-heart catheterization can help us in accurately measuring certain parameters such as pressures. We can measure the left directly measure the left ventricular pressure, the aortic pressure, and then the left atrial pressure as well, and then also directly measure the cardiac output. So we can also directly measure the vascular resistance. We can measure the systemic vascular resistance, the pulmonary vascular resistance, as well as the measurement of the pulmonary capillary wedge pressure. Of course, echo has been a surrogate for that, in which we used to measure that, but direct measurement can actually be done using cardiac catheterization. We can also directly measure the oxygen saturation. We can also measure the flow rate, the coronary flow reserve, and then the fractional flow reserve. We have, in the course of discussing the catheters, we have said that each of these catheters were produced to be adopted in different situations. So these measurements are usually obtained using pressure transducers that are attached to the catheter, and then also using the thermodilution techniques, in which involves injecting saline to measure cardiac output. We also have the fixed principle, which helps calculating cardiac output based on oxygen consumption, and then angiographic analysis as well, which is how we assess coronary flow and then vascular resistance as well. Then the hemodynamic and findings from the left heart catheterization can help us accurately diagnose and manage conditions including heart failure, valvular heart diseases, coronary artery disease, and then cardiomyopathies. And this accurate measurements of the hemodynamics help us to assess disease severity, guide treatment decisions, and then monitor response to therapy, and then improve patient outcomes. And then for the risk or complications of catheterization, left heart catheterization, of course, one of the commonest risks is the risks are usually avoided pre-operatively, adequate history, and then adequate history taken, and then the rest of the measures were put in place before the procedure. One of the risks usually is bleeding or hematoma at access site. This is usually post-procedure, usually secure, stopped by hemostasis. And then we also have the contrast media reaction, or the contrast-induced reaction. And why I lost, I was trying to say that minimizing contrast reaction, history helps us take care of that. And then the pre-operative assessment, investigations, renal function tests, especially the albumin creatinine ratio, and then history, previous history of contrast reactions help us to minimize these. And then, of course, when we do the albumin creatinine ratio or the pulmonary filtration rate, it helps us to understand the renal status of the patient, such that if there's going to be we're going to have serious problems with contrast-induced reactions on nephropathy, then alternatives are usually advised. Now, to take care of the problems related to contrast reaction, we have talked about history. However, we have these days we have the non-ionic contrast media. Of course, we have the ionic media, and then the non-ionic contrast media. The thing with the ionic media is that they are less expensive. However, because of their high osmolality, they have a higher incidence of adverse reactions. And in this, it is in this situation that the non-ionic contrast media finds good use. However, one of the problems with the non-ionic contrast media is that they are more expensive. However, they are usually of lesser osmolality and have a lesser chance of causing contrast reactions or contrast-induced nephropathy. Of course, in specialized situations like diabetes and all that, we need to be more careful with that. Then, as part of the measures to minimize the incidence of contrast reactions, one of the methods adopted is the use of carbon dioxide in angiography. The advantage of that is that it causes lesser contrast reactions, contrast-induced nephropathy. But you wouldn't want to combine this carbon dioxide with nitric oxide, because nitrogen reduces the solubility or excretion of carbon dioxide. So we have to avoid this. And then if you want to use do a carbon dioxide angiography, or if you want to use it in catheterization, you also have to adopt the use of a capnography, which helps us to monitor both the ventilatory and the intravascular carbon dioxide retention, so that it minimizes the chances of toxicity. Then rarely you also have, of course, you also have radiation exposure from the procedures surrounding procedures in the cath lab and all that. Then you also have rarely coronary artery dissection of vessel closure. And you also have the false aneurysm, which is a pulsating clot next to the hole in the artery, which would require either surgical treatment or injection of a substance to life. Now, that is could be a complication of the procedure. However, the risk of death is attributed to severe or acute illnesses that were not really well taken care of pre-operatively, and then it is said to be about 1 in 1,000. So it's actually very, very minimal. However, in situations you can't have that, but it is less reduced because of advances in the procedure. Yeah, by way of conclusion, left heart catheterization angiography is a crucial diagnostic tool in modern cardiology, offering a comprehensive assessment of the left heart chambers coronary arteries, and then direct measurement of hemodynamics. It enables accurate diagnosis and treatment of various cardiac conditions, including coronary artery disease, heart failure, and valvular heart disease as well. And then helps us in, of course, with cardiac catheterization, helps us to also identify the different classes of pulmonary hypertension. And then by providing detailed information on coronary anatomy, cardiac function, and hemodynamic parameters. Left heart catheterization guides us in, please, can you go down? In making better treatment decisions. It helps us informing medication, interventional or surgical interventions for our patients. Of course, we want to give our patients procedures that will give them the best outcomes. Then risk stratification, it helps us identify high-risk patients for closer monitoring or aggressive management, and then follow-up as well. And then prognostication, it helps us in estimating long-term outcomes and guiding patient counseling. And then research and development, advancing our understanding of cardiovascular diseases by the chance that cardiac catheterization provides us with, helps us in making clear diagnosis and then improving treatment strategies. Of course, in our research, especially for our part 2 work, there are lots of catheterization-based researches that we could have actually done. However, because it's not readily available, that has become a very, very huge limitations. And while carrying out some risks and limitations, the benefits of left heart catheterization and angiography far outweighs the drawbacks. And as technology advances, this procedure will continue to play a vital role in personalized cardiovascular medicine, enhancing patient care and improving outcomes. Thank you very much for listening.
Yes, thank you very much for this very comprehensive presentation. So at this point, I'll open the floor for questions and comments. Any questions or comments? Okay, so while we wait for questions and comments, thank you once again. It would have been really good if some of the things that you spoke about, the application of left heart catheterization, if you had examples of images to show, because really those are the things that are being asked. For instance, with the coronary angiography, images of the standard views, you know, to see the arteries, the outline of the arteries. It also helps to remember the concept well. And also even the ventriculogram is also a very good thing to see the images, and even some examples of conditions that could be diagnosed in the ventriculogram. I think one of the questions we looked at in Braunwald, there was a ventriculogram of Takotsubo cardiomyopathy, when you see it clearly in systole, the ballooning of the apical portion. So that is also very important. Also during the procedure, sometimes you can get difficulty finding the coronary ostium to be able to inject dye and see the outline of the coronary artery. So in such cases, you can do a mini aortogram. So wherein you inject dye into the aorta, it outlines the aorta well, and it can be able to show you where the coronary ostium are, because you know there can be certain congenital anomaly with anomalous origin of the coronaries. So in such cases, when you do a mini aortogram, it outlines, and then now you can see where the ostium is, and you're able to catheterize. Okay. And then also another important thing that will be good, probably we would need to on our own reading, try to look for images of those are the pressure tracings of each of the areas that you'll be going through in the left side of the heart. So when you are in the aorta, what does the pressure tracing look like? Because at times, you know, even though you have to have a knowledge of the anatomy to know where your catheter is, but then you confirm it with the tracing that you are seeing on the monitor. Okay, so you know that when you are in the aorta, the pressure should not fall below 60 roughly, because if it goes below that, then you are having problem. Either you're having some severe aortic regurgitation when your diastolic pressure is very low, or you are not in the correct chamber. Okay, so also when you are if you are in the left ventricle, you should be able to know what the pressure tracing would look like. Okay, wherein now you will have the pressure falling down, even sometimes to zero in diastole, and then going up in systole. So all of those pressure tracings are very important, and also some of the pathologies that can be diagnosed, like the broken broth phenomenon, when you have a dynamic LVOT obstruction, how you see it in the tracing. Those are also important things. And those are the areas that they ask questions on. So those tracings are very important to look at and understand them. Okay. I want you to just, if you are asked, say, explain the process of radial cannulation for coronary angiography. If you're asked such a question, how can you respond to that? Hello? Hey, was I audible?
You were.
Oh, okay. Or maybe the presenter has gone off again.
No, Chief, I'm here, sir. Sorry, I muted myself to listen to it. I was.
Okay, so just to explain to us the process of radial cannulation for left heart catheterization when you're accessing the radial artery.
Hello?
Yes,
Sorry,
please.
while he's trying to get his answers, I just need a clarification.
Yes.
Is the topic left heart catheterization or cardiac catheterization?
It was left heart catheterization. So we did right heart the last time. So now we look at the left side, and it was asked to include coronary angiography.
Okay, because I was wondering, like, if you're asked to talk about left heart catheterization, do you include coronary? Because I thought they were two separate. Well, they are both catheterization, but they're separate types of catheterization. So that was just my concern, actually.
Okay.
So he talked about both the coronary and then the left heart.
Yes.
All right then. Okay, then he should have actually discussed the pressure tracings in the
yes.
left heart. Yeah. All right. Thank you.
Chief, can you hear me?
Is it still not?
Yeah,
wait, let him respond to the first question. Dr. Austin, can you let him respond to the first question, then you can ask.
Okay, thank you.
Okay, Chief, you're asking me to describe the radial access, sir.
Yes, please.
Okay, so I've said for the radial access, first you want to do the Rebel or Allen test, in which case you access for collateral circulation and then adequacy to the hand.
Yes.
And after that, you position the side, the arm is positioned usually by the side of the board, and then you have to also make sure that the hand to be used is, especially the left hand, is the wrist is hyperextended.
Yeah.
Can you hear me, sir?
Yes, please.
Then you have to ensure that the wrist is extended, especially for the left hand. And then for the left radial access, the puncture is usually done with the hand positioned over the chest or left groin, supporting the elbow. Usually Before the radial puncture, however, you want to pre-medicate the patient. When I was talking, I talked about possible pre-medication with either midazolam, fentanyl, or nelbuphine to avoid radial spasm, which may be provoked by anxiety. And then when you're doing that, it's usually advised to do your puncture at a point about 2 to 3 centimeters above the left hand crease, where the artery is best palpable. However, if you want to do a subsequent attempt, it is advised to go about 1 centimeters above the point of the initial puncture. Then after injecting the local anesthetic at this point, you now insert about 20G cannula using what is called the Seldinger technique. And then you see a block of blood, and then you can now introduce the catheter, which is usually guided and then into the left sides, and then to begin the procedure you want to do. Of course, this usually lasts about 40 to 60 minutes. And then after the procedure, you remove the catheter, and then you secure hemostasis. Of course, you would have done a pair of assessment, history taking, ECG monitoring, and then blood pressure and all that.
Okay. So just some important details to add. So the puncture, it can be done either by the ultrasound guided or without ultrasound guidance. Okay. So mostly operators do it without ultrasound guidance, but sometimes you can get some difficult, radial access. You may need ultrasound to be able to access that. So for the non-ultrasound guidance, like you mentioned, it's a Seldinger procedure. This one can be, an exam question. They can ask you how the procedure is done. So it is good to be able to go through it step by step. So the first thing, after you've prepared the place, like you mentioned, hyperextend by putting a ball behind the wrist, you have to infiltrate the area with local anesthesia, okay, where you're going to do the puncture. So after you've infiltrated the area, you palpate the radial artery, okay? You palpate the radial artery, you feel the radial artery, and then you use the needle, the 18 to 20 gauge needle. So they have the special needle for the radial puncture. And then you are palpating the pulse with the finger on one hand, and then use your right hand to introduce the needle to get into the radial artery. Okay, so you have to introduce the needle at 40 degrees, at an angle of 45 degrees, sorry. So you puncture. When you puncture the radial artery, you will obviously see pink blood ooze out of the needle, okay? So when that happens, you now do a through and through puncture. So you push the needle further and go beyond the vessel, and then the blood will stop coming out. At that point, you take your guide wire, okay? You take the guide wire, and then you use between your finger and thumb, slowly retract the needle again to get back into the lumen, okay, with the guide wire now on your other hand. So you are retracting, and the guide wire is waiting to enter once you see the arterial blood start flowing. So you retract slowly, slowly, slowly until the needle gets back into the lumen. Once it gets into the lumen, you see blood start coming out. And then you introduce the guide wire. And it's very important that you have to be gentle introducing the guide wire. And if you meet any resistance, you should not force it, because the wire will just kink and you lose the access. So slowly you manipulate it until the guide wire goes in. And then once the guide wire goes in, just like the Seldinger procedure, you take your knife and make a small nick over the needle. Once you make the nick, you totally remove the needle with the guide wire inside. And then now you take your 6 French sheath and introduce it over the guide wire. So once the 6 French sheath goes right in, then you now remove the trocar of the sheath all together with the guide wire. And then you are inside. Then now you can connect, introduce your diagnostic catheter, or connect to the pressure monitoring system. Okay. All right. So are there any other questions? I think Daniel had a question. You can unmute and ask.
Thank you, Dr. Also, for the wonderful presentation. I just want a little clarification. You talked about transeptal perforation. So I was just looking what access would be suitable to actually have that done. Will it be the arterial access? Will it be the venous access? And I think in instance where the patient has aortic, mechanical aortic valve, what access would be a bit preferable to access the coronary? Will you still need a transceptor in that instance, or you can still go ahead with your catheterization through the ostium? Thank you. I don't know if the question is clear.
Yeah, then I believe, okay,
The
I said
approach for
there,
that.
yeah, I said there are some specialized access techniques in some specialized instances. And then if you want to assess prosthetic valves generally, most people want to adopt the transeptal approach. You understand? Because it gives a better assessment of the aortic valve, especially around the ostium or thereabouts.
Okay, so the clarification I just want to make is that if the guide wire goes in, it goes into the arterial pathway as it were like that, and then it enters to descend. It should descend towards the, I think, the descending aorta, then to be able to access where the ostium is. But my confusion is just that if you're looking at transeptor, that means you're perforating from one atrium to the other. So I was thinking, I don't know, I was just thinking, is it possible to do your right catheterization, then you puncture to access the left, to actually assess what is happening in the left?
Yes, you can actually do that.
Okay. So is it like a standard procedure to do such that, because I read at the point also that if for patients who have like aortic mitral stenosis, that you actually want to look out for your pressures and then do maybe work on the valve on that side.
Yes, that's actually correct.
So do you do like a right catheterization, then when you get into the right side, and you can do your puncture to access the other side?
Yes, if you have difficulties accessing that area through the left side, you can do a transeptal puncture. So that's why it's part of the specialized techniques, not usually routinely used, except in some difficult situations.
Thank
so
you
you
very
can
much.
actually come into the right side, puncture, and then do the evaluation you want to do on the left side.
Thank you very much.
And please, if there's any contribution, I will appreciate to the question.
Okay. Good evening. I have some contributions to make, not on this question, on the presentation in general. I don't know if I can go ahead.
Please go ahead. Go ahead, please.
Okay. Thank you very much. Thank you, Dr. Also, for a good presentation. I wanted to just make some contributions on, number one, the access. Like we said, radial is now preferred, although most centers still use the femoral. But when it comes to interventional procedures, most people will prefer the femoral. This is because the sheets, a radial access cannot really take more than a 6 French sheet, like Dr. Conte said. Most people will use a 5 French in radial access. So for when you want to do a lot of manipulations in and out, and the higher sheet you use, the higher the chance of what they call it now, radial artery constriction, which you mentioned. So because of that, they can give this vasodilators, intraarterial vasodilators. There is a combination of nitrates and calcium channel blockers given intraarterially, okay, to help to relax the radial artery and allow the catheter to pass. Okay, then when talking about the procedure itself, most people will start with right coronary, because they usually start with it, because the catheters for the different blood vessels are different. There's a separate catheter to image the right coronary. There's a separate catheter to image the left main, that's the left circumflex and the LAD. Then there's a pigtail, the one for left ventriculography, which is used to assess ejection fraction. It's used to assess regurgitation. Okay, that's the catheter used for that is usually called the pigtail catheter. So there are different catheters that assesses those different things. I think, I don't know if I have any other thing to say, I'll say it. I'll unmute and say it again. That's all for now. Thank you very much for a good presentation.
Hello?
Yes, please. Go ahead.
Yes, I just need a clarification. I know during the explanation for the radial access, he mentioned the Seldinger approach, but during the presentation, it was a separate approach he mentioned. Dr. Ozo, please, can you just say it again? The approach he mentioned, modified something.
Okay, the modified Sons method is actually like the modified Sons method is actually like accessing the radial. That's the radial approach. You understand? However,
modified what?
The modified Sons method. That's a method of accessing the radial approach. You understand?
Okay.
Yeah. So let me clarify. So in terms of accessing the artery, okay, accessing the artery, then you have to follow that modified Sons procedure, wherein you palpate the artery. You have to palpate, you're feeling it, and then you introduce the needle at 45 degrees. When you enter the artery, you see blood gushing out. You continue further, you go through and through the artery, and then the blood will stop flowing. Then you get your guide wire. So from the when you get your guide wire, you start bringing the needle out until you are back in the lumen and blood starts flowing. Then you introduce your guide wire. So after you've introduced the guide wire, everything that you do after that is the same as the Seldinger's procedure.
Yeah.
Okay, it's introducing, because this one you are cannulating a directly palpable artery. You can palpate it and then enter it. Okay, that's the difference in the access. But after you gain access, you enter the guide wire. Everything else you do, you cannulate with the sheath and all, is the same as what you do with the Seldinger procedure.
So Dr. Samuel, that's after I'm injecting the local anesthetics at the Seldinger site. Sorry, at the puncture site.
Okay, any further questions or comments before we take comment from our chiefs?
Please, this Seldinger's approach, is it not the same Seldinger technique we use for catheter, cannulation in dialysis, hemodialysis?
Yes, to access the hemodialysis catheter, subclavian vein catheterization, it's just the same procedure. It's just that in this radial one, you are directly palpating the vessel that you are going to enter. But in those other ones, you cannot directly palpate the vessels that you are entering.
Yeah, then Chief, in catheterization, for the radial access, what you use is the Seldinger approach. However, if you want to use the femoral, that one is called the modified Seldinger approach. But honestly, I don't know the difference. If anybody can explain in details.
So if you are doing a femoral access, the major difference there is that in the femoral access, once you have to palpate, because it's an arterial access, you have to palpate the artery directly and then you cannulate it. But in the femoral, once you enter the artery, you have to get your guide wire and thread in the guide wire straight away. You don't puncture the femoral through and through. Okay, that's the main difference. With the radial artery, when you get into the artery, you go through it. Okay, and then you begin to retract your needle until you get back in, then you introduce the guide wire. But you don't do that in the femoral. The femoral, once you enter with the needle, you get into the femoral artery, you have to bring in your guide wire, thread your guide wire, and then the rest of the procedure is the same.
Thank you very much, sir.
Hello.
Yes, please.
Yeah, thank you very much, Dr. Ozo. We really appreciate. Just as a follow-up for just what Conte has said earlier on, do you have any, because in the exam setting, they can likely go very funny. Do you have any picture of carbon dioxide as a contrast? Because we are used to the regular ionic contrast that we know all around. So we know what the contrast looks like, really, assuming we see the picture. I don't know if there's
maybe I'll have to add that. Yeah, that I'll look for it. But however, I didn't really add that because if I now start talking about contrast media, ionic and unionic types of contrast and all that, we'll have a lot of slides. So, and the other things that Dr. Conte has pointed out that I'm actually seeing that I wish I'd added too. So I will have to them and send to the page.
Okay, thank you. Just the slide we do. Thank you very much. Just as a follow-up, if you could have like 4 or 5 options of ionic contrast and 4 or 5 options of non-ionic contrast, who knows whether they will bring it in multiple options? So we should be able to equal help guide us in our readings and in MCQ. That's that. Thank you. Now, there is something you said during the presentation I did not get quite clear. The assessment of pericardial space. How do we do that? Do we puncture the atrium to get the pericardial space? Hello, sir. Hello.
Please come again.
Yeah, there is something I don't know whether I really got right when we were presenting. You talked about assessment of pericardial space.
Yeah.
Yes. How do we really get that? Do we puncture the atrium just to get into the pericardial space for the assessment?
Puncture the atrium?
Or rather, how do we get to the pericardial space for assessment through through catheterization, for example?
Okay, Chief. I added that as one of the procedures. However, of course, when I guess you can do that through a pericardiotomy, especially in situations whereby you want to assess the pericardial space, and then maybe if there's any pericardial related issues and all that. So you don't need to necessarily go through the pericardial. I think you can. It's one of the things you can do during pericardiotomy using one of those catheters as a form of specialized approach in catheterization. So I think it's the pericardium you essentially need to puncture, but I don't know exactly which area, but I think you also want to adopt the area with less chance of causing trauma in the course of the procedure. So it's one of the specialized techniques, however, it's not routinely used. But if you want to make a direct assessment of the pericardial space and issues related to it, sometimes people try out this.
It's okay. It's okay. Thank you.
Yeah. Hello. Hello.
Very well. Yes. Conte.
Yeah. So there are sometimes in some conditions when you want to really assess the hemodynamics, you know, to know whether a patient is in tamponade, you know, or whether a patient is having an effusive constrictive picture. So some of those ones, you need a catheter in the pericardium to be able to measure intrapericardial pressure simultaneously as you are measuring pressure within the cavity of the heart, most times the right heart cavity. So you want to do measurements simultaneously. So in those cases, you just use the similar approaches that you use for pericardiocentesis. Remember the previous presentation. The most common is the sub-xiphoid approach, okay? But there are certain times if the pericardial effusion is not that large and you don't have much space anteriorly, then you can use other approach where the fluid is more. So for instance, you can use the apical approach to introduce the catheter, and then you'll be able to measure the pressure. So you just introduce the catheter the same way you introduce the catheter to do a pericardiocentesis. Okay, and it depends on where you have a good amount of fluid that you're not going to enter into the chamber of the heart. So you don't use the same catheter that is within the cardiac chambers to access the pericardium. You don't do that. So you access the pericardium separately, and then now you do pressure measurements simultaneously to be able to establish the relationship between your intrapericardial pressure and your right ventricular cavity pressures.
That's quite clear. That's quite clear now. Thank you.
Okay. So in the absence of further questions, I'll hand over to Chief Okopi to take comments from our chiefs before we move to the next presenter.
Hello, can I hear?
Yes, Chief Okopi, we can hear you.
Hello, can you hear me, Dr. Conte?
Yes, sir.
I don't know if I can hear myself.
We can hear you, Chief Okopi, at least.
Dr. Conte, please, can you hear me?
No. I can hear you, Chief Okopi. It seems as if you can't hear me.
All right, I don't know.
Are you getting me?
Okay. Well, can you hear me?
Yes,
I can now. All right.
Yeah.
Okay, thank you so much, Dr. Ozo Chibuike, for that very brilliant and scintillating presentation. You did very well, at least. We could get a whole lot. And then with the help of Conte, who has been in the cath lab and is living presently in the cath lab, we're getting clarification. So thank you again, Dr. Conte, for the experience you're going through. I love that you live inside the cath lab, so it's giving us better insight. Even though I've watched some of these procedures, I only observed them, and now I'm getting a little bit clearer concerning some of them. Before I ask a question, let me just call on Dr. Allison. We'll be very brief because we have another presentation to take today. So, Dr. Allison, if you're there, can you make one or two comments?
Yes, thank you. Good evening, Chief Okopi. Thank you. Good evening, everyone. Thank you, Dr. Ozo now. Sorry if I didn't pronounce it well, for that detailed presentation. Is actually not an easy topic to take. You had a lot of things to talk about, but you touched on so many things that might be required in exam. So just to clarify some questions about the access that who asked the question now? Dr. Odoye asked. You know, the one he described freely, that's the one when you go through the femoral artery now, or through the radial artery, or through the brachial artery. That's the retrograde technique, because you are going from the aorta through the to the left side of the heart. So that's retrograde technique. So you can also go antegrade. So the antegrade technique is the one that you go either through the veins, so to speak, femoral vein, brachiocephalic, jugular vein. You are going into the right side of the heart from the superior or inferior vena cava, and that's the antegrade. And you are doing a transeptal puncture to access the left side of the heart. So that's antegrade, in case you see it in exam. So that's antegrade. And those ones are indicated in cases when you have situations that preclude access through the aorta. If the patient is on a pump, if patient has coarctation of aorta, if patient has some other things that preclude. And again, those are the access that are indicated when you need to do like a balloon, what do you call it now? For mitral stenosis. So you go through the antegrade technique to do the balloon valvulotomy that we do actually. So that's the antegrade. Then we can also have the apical approach. Apical approach is when you do a direct transthoracic left ventricular puncture. When we have maybe situations where we have both maybe stenosis, that's aortic stenosis and mitral stenosis now, or you have a lot of complications, and you need to actually assess for pressures in the heart. Might not be therapeutic now, trying to investigate. Maybe the patient now has some other let me say complications, and you just need to like assess the pressures, you understand? So you go through an apical approach in case you see it in MCQ. So we have retrograde, antegrade, apical approach, and it's the retrograde that involves going through the artery now. The antegrade, you go through the veins. Then the direct, that's the apical approach where you do a direct transthoracic for MCQ purpose. So that's one. Then two, I don't know how many of us were at the NCS program that we just concluded. There are some, the ones Dr. Conte and some other people were mentioning. When you do a left heart catheterization, you have to go online and check for pictures that you see in aortic stenosis, what you see in mitral stenosis, what you see in HCM, what you see in tamponade, what you see in mitral stenosis. All those things are important because they could just bring the picture and they will ask for the diagnosis. So it's good we know. Then we should know how the arterial pressures look in the left atrium, in the left ventricle. We should know how the tracings are. It's also quite important for exam. They could bring a tracing and ask you what the problem is. Then again, when you do a left heart catheterization, you should know this issue of damping and this other one, ventriculization. So you should know all those things that I've mentioned. It's because you didn't really talk about it, but there are potential questions. Just the way we mentioned it, just go online and check for the tracings for all these things. So I think I will just stop there so that you can go to the next presentation. But you've really tried and you've done well. Thank you.
Oh, thank you so much. I think you also touched the aspect I wanted to ask him, or maybe request if he could add them in his slides. probably the clinical relevance to cardiac catheterization. Dr. Ozo, you did very well if we are going to be asking the exam to describe the procedure. But you know how the examiner is, most of the things should be applied. So some of these things that she mentioned, ventricularization, damping, and particular tracing away from particular diseases with respect to valvular heart diseases and co. Even if you can get us pressure waveform for dynamic and static, dynamic obstruction, LVOT obstruction, and co, all put together, so that we can have them as part of your slide. If that is possible, we'll be very, very happy.
And I'll work on that, sir. Definitely.
All right, because that's basically what these guys may be seeing in the exam. So when they get to go through your slides, okay. So it might just be like a part of your slide presentation, clinical relevance of left heart catheterization, and then you mention HOCUM, you mention all aortic stenosis and subvalvular, supravalvular, all put together, and then we'll get to know more about it. Do you know the name of the cocktail given for radial access? I think there's a name for it to prevent spasm. I remember when I was at Evercare Lekki for some sessions, there's a cocktail they're calling me. I don't know if you know that. Conte, do you have an idea of it? Of course, Dr. Charles Okorie tried mentioning it.
I didn't really come across. Oh, sorry.
All right. So in our center, mostly, to prevent spasm, we normally use nitroglycerin. Yeah, we can give anything between 200 to 400 microgram of nitroglycerin intra-arterially. After we've cannulated the artery, we'll give it. And then after 1 to 2 minutes, we continue the procedure.
Okay. Maybe
so Chief, in the absence of that, so I've also said the patient.
Please go ahead, please.
As I said, will be treated with either midazolam or fentanyl as well to prevent the radial artery spasms, which may come from anxiety. So alongside the nitroglycerin Chief talked about, I didn't know about the.
Yeah, you're right. Dr. Charles just gave it nitroglycerin, verapamil, and heparin. It's a cocktail. It's a mixture they usually give at the site. I think there was a name they called it, but then this is the concentrate. Nitroglycerin, verapamil, and heparin. I remember while we were trying to get a radial access, there was this vasospasm that shut the place up. When they gave the cocktail, it opens up again. And of course, the patient was on diazepam to reduce the anxiety. All right, thank you. It's always exciting, but when you have a cath lab, these things come alive again. So perhaps some of us without that experience, we may have to go through it theoretically and have it in our memory. But let's try as much as possible to have the clinical relevance of left heart cath. So with this, if there are no other contributions or questions, we want to thank Dr. Chibuike Ozo for a very brilliant presentation as we welcome Dr. Florence or Dr. Conte to take the next presentation. Thank you.
Yes, thank you very much, Chief Okopi. So Dr. Charles Okorie, if you can please share your slide.